All right, well, I would like to welcome each of you to our launch day for the Community of Practice, which is a Project ECHO in East Africa, focusing on palliative care in humanitarian settings. And we're very excited that you have come to this session, whether you're a participant or whether you're a faculty member or a volunteer and wanting to just witness and observe today. We're really glad that you're here. We are welcoming you to a community of practice, and a community of practice may be a new word that you might not have heard of before. And we want to introduce you to this concept. At PallCHASE, we are an international network of palliative care and humanitarian providers that are trying to better integrate palliative care approaches for patients and families and individuals that are living in humanitarian settings around the world. And for the last few years, we've been running Project ECHOs, which they are training courses for continuing medical education, as well as nursing education in a cross-cultural and multidisciplinary setting. And we've run them for the last few years in East Africa, and we're quite excited today to be launching our first community of practice. This is a collaboration between several organizations. We want to acknowledge the Africa Palliative Care Association, who has continued to support the work in the region. They are the Regional Association for Palliative Care in all of Africa, or Continental, I guess, Association, to relieve pain and suffering for individuals that have life-limiting or life-threatening illnesses. We also have Two Worlds Cancer Collaboration, which is an organization in Canada that continues to support the promotion of palliative care in difficult settings, such as refugee camps or in conflict settings. PallCHASE, as I mentioned earlier, is a network of providers as well as humanitarian workers that are trying to find better ways to support palliative care initiatives in different regions. And I've been honored to be part of the group for a few years now as well, and I will be leading the session today. My name is Erin. I'm a palliative care nurse from Canada, currently living in Nairobi, Kenya. And of course, we don't want to forget Project ECHO. Project ECHO is a model of teaching and engaging together that uses technology to help disseminate health information. So I'm really glad you are joining us today. Today is October 17th, and today is the day that we're launching our group. So welcome. If you want to take a minute to put your name in the chat, we'd love to get to know each of you. We are going to be a big group. We've had over 150 people register for this monthly community of practice. So we would love to find ways to get to know you. So if you can put your name in the chat, that would be great. And if you can rename yourself, just so that we know who's in attendance, that would be great. So if you click on participants in Zoom, at the bottom of your Zoom, you can hover over yourself, and in the very, click on the blue More button, and you'll see a place to click rename. Some people will show up as their phone. Many of you are already, I guess, registered through Zoom, so it remembers your name. So if you can do that, and you can put your name and where you're working, which organization you're working for, and then which country or region you're working in, just so we can get to know you. And welcome again. So I'd like the chance now to just welcome the faculty members. You'll see that there are some people on the call that have a hashtag in front of their name. You'll see that on my name there. We have several other members that are faculty, and I'd like to take a minute just for them to say hi. Some of them may be working and living in your region of the world in East Africa, in this part of the world. Some might be from other places, and this is one great way, because of technology, that we can all connect. And actually our faculty members are very personal, and they would love to get to know you. So I'll just take a minute looking at our list just for you to say hello and wish the group well over the next, we're going to be meeting for 12 months. So let me just take 1 minute to allow people to introduce themselves. Ali, would you like to start? Ali Hamis?
Yeah, Erin does. I'm in the Dadaab refugee camp, one of the faculty members. I'm a clinician. I'm one of the PallCHASE team. I'm one of the networking group members in East Africa. I'm very happy to join you again. Let me say hi to all other colleagues. Thank you.
Thank you so much, Ali. And if you are currently working in Dadaab refugee camp, try to get Ali's contact. Him and one of our other faculty members, Annalice, are really spearheading the palliative care work along with the other INGOs in the area. So please do connect with him. Sarah, would you like to introduce yourself? Sarah Renaud.
Hello, everyone. I'm so happy to be here. Thank you, Erin. I am a Canadian nurse who has worked in palliative care and am currently living in Nairobi and working with Erin at Faraja and also in promoting palliative care in humanitarian settings. So I'm very happy to be here and so happy to meet everyone.
Thanks, Sarah. And I guess if you're based in Nairobi and you would love to reach out to Sarah, she is living in the Nairobi area. So please do connect with her. She's been a palliative care nurse for many years in Canada. We're grateful to have you in the region, Sarah. Esther, would you like to introduce yourself? Esther Beatty.
Sure. Good morning. I guess good afternoon for you, everyone. I'm Esther Beatty. I'm a palliative care nurse. I work in a hospice in Canada. I've been involved with PallCHASE for, I guess, maybe a few years. I've worked in Senegal, West Africa, and we are just almost finished our first French West Africa series, which is really exciting. And I am looking forward to learning from everybody that's joining us in this course, in this community of practice. Welcome, everyone.
Thanks, Esther. Esther also recently became a facilitator with Project ECHO, so she knows a lot about Project ECHO, although she sometimes tells us her husband has to help her out. She's a very dedicated nurse to promoting palliative care globally. So thanks, Esther, for being with us. Mohammed, I know that you're on the call today. Mohammed probably can be a guest facilitator, guest speaker. Mohammed is a palliative care nurse from Bangladesh, and he's been on many Project ECHOs. Would you like to introduce yourself, Mohammed?
Thank you so much, everyone. And this is Mohammed Piaz from Cox's Bazar, Bangladesh. And basically, I'm a palliative care nurse in Rohingya refugee camp who are from Myanmar in Bangladesh. And I am working with refugee beside host community of Bangladesh. So thank you so much and welcome to everyone.
Thank you, Mohammed. Mohammed has been working with the International Organization of Migrants, IOM, as a nurse, and he's been a great advocate, especially with PallCHASE. So welcome, Mohammed. Good to see you. I know it's late for you, or it's getting later. Thanks for joining us. Ruth Wooldridge, would you like to introduce yourself? Oh, we can't hear you. Do you want to unmute, Ruth? Sorry.
Hello, everybody, and it's great to be part of this new organization where we can all share and we can all learn so much from all of you. I'm on the PallCHASE Education Committee, and I also represent Palliative Care Works, which is a small charity here in England that takes palliative care training and mentoring overseas. And we've worked in Kenya and Tanzania, Ethiopia, and all sorts of other countries. So great to be part of this.
Great. Thank you so much, Ruth. It's so nice to have you. And I know you guys just finished your online and your annual conference. I hope it went really well over the weekend.
It did. We learned a huge amount from each other, and from Heather Richardson, who some of you may know.
From Kenya.
A fellowship through St. Christopher's.
Great. We'll have to hear more about it after. Thank you, Ruth. Dr. Zifra Ali, would you like to introduce yourself?
Good afternoon, everyone. I don't know if my video is on or not anyway. My name is Zipporah Ali. I'm a palliative care physician, kind of semi-retired, but still very active. I've been supporting Erin in this project as maybe giving lectures now and then. And I'm happy to be part of this team because my interest in palliative care and humanitarian crises or situations or conditions, depending on what you call them, or settings, started way back when I started working with the National Organization for Hospice and Palliative Care during my first time to go to Dadaab and Kakuma many years ago, I don't know, like 14 years ago, to train people there. But I also went some time back in 2018, I think. And I know that the people who work in these places really face a lot of challenges. So I'm happy that we're having this training and learning from each other that can help them at least support people who are living in tough conditions. I just wanted to say that Truth always forgets to say she's the one who started the first hospice in Kenya. So she and another nurse and late Professor Kasili were the brains behind the Nairobi hospice. So I hold a very special place for her in my mind, my heart, because she actually set up palliative care in this country. Thank you. Mm-hmm. I'm looking forward to the sessions that I'll be able to attend. Thank you.
Yeah, that's very true. We have some very strong legacy work here on this call. And Ruth, you're still very well connected because of Zoom and all of your work with Palliative Care Works. Thank you, Ruth. And of course, Dr. Ali, Zipporah Ali, just recently retired from APCA, the National Association here in Kenya. And we're really grateful that she continues to give of her time and her expertise, especially to the PallCHASE team. So thank you also, Dr. Ali. I think we have a few others on our faculty team. You'll see anyone that is a faculty member should have a hashtag in front of their name. And I see a bunch of you are introducing yourselves in the chat. Sam Fun, could you introduce yourself? Calling from, I believe it's Indonesia, one of our faculty members in Southeast Asia. Maybe her connection is not so good. She's one of our members with PallCHASE. Maybe I'll ask her to put her name in the chat. And then we have our two speakers today. So I will allow them to quickly say hello and I'll give a longer introduction. Today, we just have a bit longer of an introduction today because it's just our first session. We also have Dave Farron from the Global Health Academy with us today. Dave, I don't want to put you on the spot, but if you'd like to say hello to everyone from Edinburgh, you're welcome.
Yeah, hello everyone. Great to be here. It's really exciting just to see such a spread from the globe, really. It's really exciting.
Yeah. Thank you so much. Thanks for joining us. Okay, Dr. Esther Nafula, do you want to say hi quickly to everyone and then I'll introduce you more officially before you talk?
Good afternoon, everyone. My name is Dr. Esther Nafula. I'm a palliative medicine physician working in Kenya. Thank you.
And we also have Annalice Otoro, who is our faculty member, and she is a nurse. Annalice, do you want to say hi to everyone?
Hi, everyone. I'm Annalice Otoro, a nurse for IRC, Agadera Refugee Camp. Thank you and welcome.
Great. Well, thank you so much for being with us all here today. And I think maybe Ali or Esther, if you see someone else that joins in, if you just let me know before we start the session if I've missed anyone, but I think we should be okay for now. But thank you so much. We have many faculty members that are part of this community of practice as well. And we again want to reiterate how important it is for you to know that we are accessible. We don't want to have any barriers between participants and faculty members. And as Dr. Ali was saying, we want to learn also from you in this course, or in this community of practice. We were hoping to have the APCA team with us today. I don't see them on the call, but that's okay. They will give their regards when they join at some point. So thank you. Welcome, a big welcome to all our participants. We've had 150 people register for this community of practice. We are quite excited to have new individuals as well as people who've attended a Project ECHO before that has been run by PallCHASE, and we're really excited for you to be with us today. I see Quite a few people have introduced themselves in the chat. We have people from Dadaab, which is wonderful, Rwanda. We have Bang Bull from South Sudan, working with MSF, IRC in Hagadera. We have a nurse from Ghana, welcome. People working with the Kenya Red Cross, Kenya. Great to see you all with us today. So a very warm welcome to each of you. We have Leah from Kakuma, which is a refugee camp in Kenya. Yeah, it's great to see all of you. Oh yes, here, pediatric. Dr. Samphon is a pediatric hematologist in palliative care as well from Cambodia. Sorry about that. I got the East Asian country wrong. It's very nice to see you all, and I welcome you to the session today. So when we talk about ECHO, we want you to know that ECHO means all teach, all learn. And this is a supportive community of practice where lessons can be shared, questions can be encouraged, and we always try to have discussions around cases. And this is really important to us. It's going to be run over 12 sessions. So we're going to be meeting once a month, starting today and then going into 2024. We will have each session have a teaching topic that will be led by a palliative care or humanitarian health expert. Then we will have time for discussion, and then we will do a clinical case presentation. This will be a little bit different than in the past because we're going to be asking you as participants or primary healthcare teams or even palliative care teams on the ground to bring your cases to the sessions. And we are really looking forward to hearing and discussing and working with you to come up with some solutions to your questions and the discussion time around the cases. If you are interested in presenting a case, I know that we have some lined up from South Sudan and Kenya over the next few months. Please reach out to me through the email and I'll put it in the chat. And we would love to find ways to encourage you to present. Public speaking is sometimes difficult and it can be a little bit nerve-wracking, but we hope that we will have really good participation from all of our teams in the field. And this is one way for you to learn and to grow in your leadership skills. So this is what ECHO is like. We are considered the hub in the middle at PallCHASE, Two Worlds, APCA, and Project ECHO. And we are working together with our hub expert team. So any of the faculty members would be considered the images here in the black, where we are all part of the hub. Oops, sorry. You as a participant could be considered a spoke. So depending on if you're listening to this call with your other teammates or your colleagues, you would be considered a spoke. And then the community health workers, colleagues, or patients that you impact based on what you learn during these sessions are the ones in the lighter blue there. And this is how it works. We engage with you on a regular basis so that you can begin to change the way you care for your patients and families. And we know that we are going to be using Zoom for our sessions, so we would love if you could keep your video on if your bandwidth allows. Please do keep yourself muted to avoid any background noise, and then if you can just make sure you're labeled correctly. So when we call on you or when we ask you to introduce yourself, we use your right name. If you have any questions, you can put them in the chat or any comments to questions. And the facilitator, like myself, will call on you if you to be part of the discussions, and I'll ask you to unmute. If you do have a question, I guess you can also use the raise hand aspect in Zoom. We are using iEcho this time for our East Africa Community of Practice, and this is what the website looks like. You'll see on the website, it has a schedule, it has our content, participants, and here it will show the different dates and what we'll be talking about each time. You can log on to our calls, which then gets redirected to Zoom from this website. And we also are really excited to be able to share that we also have an app. So if you use an Apple phone, you can actually download the Project ECHO or iEcho app. So I'll just leave this on the screen for a minute. It's actually very easy to join our ECHO calls on your phone using this app. And we also have the app for Android. I've shared this several times in the WhatsApp group, but if you need to, you can also click on the links. And this is for Android. So if you have an Android device, You can download this app and it will send you a reminder about 20 to 30 minutes ahead of our call. And then you can join directly from your phone. You don't have to look on your email for the link. We won't be sharing regularly our Zoom links because we are hoping to be able to use some of the attendance tracking extras that this app gives us, or the website. So thanks for being supportive in this. So for today, I think I'm gone quite over time. I'm very sorry about that. Dr. Esther, we'll make sure you have enough time for your presentation. But I'll be finishing now with the introduction. Then Dr. Esther Nafula, who introduced herself as the head of palliative care at Kenyatta National Hospital, will be presenting the teaching for today. We'll have a short time of discussion and then we'll continue. We'll then continue with the case presentation from Annalice, who will be sharing a case from Dadaab refugee camp. Today, most likely, we will not go into breakout rooms unless we have quite a bit of time at the end, because today is the first day and it's taking a bit more time introducing the concepts to the group. But yes, and then we'll and then we'll end with any announcements if you have any questions. So I will hand it over now to Dr. Nafula. Let me just make you a co-host so you can share your screen. Dr. Nafula has been supporting PallCHASE and the work in the region for several years now, and we're really grateful to have you on the call today. So over to you, Dr. Esther.
Thank you. Okay, I'll start sharing my screen. So this afternoon, we are going to talk about family-centered care, and of course also in the context of the humanitarian world. So I'll just start projecting. Sorry, my screen is crowded. So I hope you're able to see my screen.
Yep, looks great.
Okay.
Yes, we are seeing, yeah.
So at the end of this session, you should be able to discuss what family-centered care is. So we are going to just look at the basics of what family-centered care means and how you can have communication with the families in palliative care in the humanitarian setting. It will take about 20 minutes. Then we can do some questions and answers afterwards. So family-centered care is a philosophy and approach to healthcare that places the patient and family at the center of the institutional and professional purposes. So we do not just look at patients as a disease, but we look at patients as individuals who belong to families, and we acknowledge that the family matters when it comes to making decisions about healthcare. So in facilities that have implemented family-centered care, patients and families are involved in all aspects of care. That includes planning, implementation, and evaluating of health services. So it's not just about the healthcare provider, it's about what is best for the patient and their family. So what family-centered care does is to form relationships between the consumer and the healthcare provider, so that it's not just that patients are either complimenting us or complaining about the service that they have received, but the patient actually feels like their opinion matters and the families feel that they have been listened to. So the traditional approach of care was that the doctor was always right in the hospital, the healthcare providers are right, and the patient has no say. The patient or family should not ask questions. They should not ask for clarifications. If it is a diagnosis, the patient is handed over a diagnosis and told you're suffering from this disease, this is the treatment you're going to get. Or sometimes they're not even told, you're just told go to the pharmacy, go to the lab. So this traditional approach really disempowered the patient and the family. The patient was at the mercy of the healthcare provider or the system. So again, there was heavy reliance on science that This is the physiology of your illness. This is the pharmacology of your medication. And this is why we are prescribing this. And it undervalues the importance of human interactions in the healthcare experience. That once an individual becomes sick, they stop to be a person and their opinions stop to matter. We're just looking at their illness and how to treat it. The traditional approach is also driven by the needs of the healthcare professionals and the healthcare system, rather than the needs of the patient and the family. And what that means is that the traditional approach of care was more focused on the illness and providing a solution to the illness and what was good for the healthcare professional as opposed to what is good for the patient. But family-centered care, what it helps us to understand is that the family is very important, that the individual that we are treating and the family are paramount. Then the healthcare providers, we are visitors. We are visitors to that family. So their opinion should matter more than our opinion when it comes to choosing treatment, choosing where to be treated, even choosing what kind of treatment they want within our institutions and what kind of support they need. That we need to support the family to continue being a family and realize that our role is very temporary in this family life, and we need to give them the support that they seek as they go through the journey of illness and interaction with the healthcare system. So imagine if your loved one was sick, your loved one is now the patient and you've brought them to a hospital. How would you like him or her to be treated by your colleague or by yourself? And you as the family member, what kind of treatment would you want? So when we have our loved ones that are sick, we expect them to be treated with empathy. We expect them to be given information. We expect the doctors, nurses, clinicians to acknowledge our loved one. And as their family members, we want to be involved. When we take our relatives to hospital, we want to be there in the consultation room. We want the doctor to share information with us, not to shove us out of the room and tell us that we are doing a resuscitation, so please stand outside. So when we wear the shoes and put ourselves in the shoes of the patient or the family, we are actually then able to give family-centered care. So family-centered care is important because first, we respect the right of the patients and their families, and this is their right to the best attainable healthcare. It is their right to privacy, their right to confidentiality. We enhance patient safety because we are actually able to involve the patient in the care. We are able to involve the family in the care. It reduces conflicts that arise among patients and healthcare providers because a lot of these conflicts come because of lack of information. The patient has not been given any information. The family has not been given any information. They feel sidelined. And it is very common to hear them say that we brought our relative to hospital and nothing has been done. So a patient has come with dehydration, you have been rehydrating them, you have identified an infection, you've been treating it, but you still hear the family saying nothing has been done. It is because they have not been given any information. Nobody has taken time to explain to them what their relative is going through. There is increased satisfaction with care, both for the patient, the family, and the healthcare provider, and there is patient participation in decision-making. So when we offer family-centered care, we put the patient and the family at the center. So we are able to have discussions with the patient, with the family, and the decisions, as much as we give recommendations in terms of this is what is good, medically speaking, this is what we recommend for this disease, this is the treatment we recommend. The patient participates in that discussion, and the decisions that are made are in line with their goals and values. So the patient feels valued. So there are some core concepts of family-centered care that I would like you to remember by the end of the presentation. That the first thing is mutual respect. So the family members, the patients, they give us respect for being their healthcare providers, and we also give them respect. Then we have patient and family choice. That what is paramount is that the patient and their family understands what their illness is, what the treatment options are, and we are able to support them with their decisions. Then we have flexibility. So when we are giving family-centered care, it is tailored to that patient and their family. It is not blanket that anyone coming with a headache will be given Panadol. But we assess, Esther has come, she has a headache, what matters to her, what is her family setup, what kind of support does she have? So when we give care, the care is individualized. It is tailor-made to suit the needs of that family. Then we have information sharing where patients have a right to information, their family has a right to information. So we share this information with them in a way that they can understand, not with medical jargon that the family and the patient are more confused than when they came in. So when we share information, we need to remember that there is the issue of confidentiality, and we need to seek consent from the patient, especially before we start divulging information about their diagnosis, prognosis, or treatment to their family. But once a patient has given us the okay, talk to the family, and they have told us these are the people who are important to me, then we can share that information. Then we are able to give the patient and their family support in the sense that once we share information with them, we can identify where the gaps are in caregiving, and we can be able to support them, not only with information, but we can support them psychologically, we can support them with practical skills. Sometimes we are sending a patient home who is feeding with an nasogastric tube. Are we able to teach the family how to use that tube? And there's mutual collaboration when we offer family-centered care. So some of the barriers to this include a lack of space. So many of our institutions do not have the space, physical space, where we can sit down with families, or even the privacy that we can sit down with families and actually have a meaningful discussion with them. Then there is poor attitudes of healthcare providers. Sometimes when a patient asks a question, we dismiss them. Sometimes when a family asks us for clarification, a family member, we feel that they're being a nuisance. Then there is lack of time. That is as a result sometimes of staff shortages. Some of our facilities are so understaffed that you are actually not able to give proper care to the patient, leave alone the family. You find yourself with 10 patients to attend to in a span of 15 minutes or 50 patients in a day. So you are not able to actually give them the care that you would wish to. Now, when we look at the humanitarian setups, the challenges even become more. Apart from the lack of space, the attitudes, the time, and staff shortages, working within the humanitarian setup also includes being constantly worried about insecurity and wars. There is lack of resources, no medication, no supplies, no lab tests. Refugees face a lot of discrimination because they are living in a foreign country. They do not have proper identification. They do not have legal systems to support them. They do not have access to health insurance. There's poor access to healthcare. There's generally a lack of information. Sometimes there's a language barrier. And we are talking about family-centered care, but sometimes there's no family. Someone has come from a war-torn country, they've come into our country. They do not know where their family members are. So they sort of have to get a new family or new support systems within the camps. Now, when you have access to the families, there are some tips here on how to communicate with the families. And first is that try to establish their level of understanding of what is happening to their relative, and then provide information based on that. And this information should not be just generalized information, but give them specific information about the diagnosis of their patient, prognosis, and treatment options. What are the best treatment options and what is available where you're working? Listen to their concerns. There is no stupid question. There is no relative's concern that is invalid. Even the patient's concerns, you need to listen to them. What challenges are they facing and what can you help them with? Because sometimes just clarifying that someone has this diagnosis, this is the kind of treatment they are getting, this is the side effects to expect from the treatment. Sometimes it actually helps these relatives when they go back home with their sick patient to take care of their patient. Then we have shared decision-making. So shared decision-making means we are able to have a discussion, not just with the patient and their family. They are able to understand the journey that their patient is going through, and we are therefore able to offer them support. We are able to help them make decisions like where do we go for treatment? Is this treatment going to work? What options are there? How can we relieve the suffering of our patient? Where do we go for if there is an emergency at home? Who should be the person we contact? Where are we able to get help? And then we are able to give them psychological support. A lot of families, especially in the humanitarian setups, will have a lot of challenges. Those challenges affect the family life, they affect decision-making patterns. And when we interact with this family, we are able to pick out and to see what kind of support are we able to offer them. Is it just advice you're going to give them? Are you able to do some support groups for them? Are you able to even support the individual family members who are having a challenge coping with the diagnosis of their relative? So maybe you're asking yourself what your role is when you listen to all these issues about family-centered care. So you do not have to be within an institution to provide family-centered care. Family-centered care is actually everyone's business and it can be done. So what you need to do is educate yourself on this philosophy of family-centered care. What does it actually mean to involve the family in a patient's care? Is it just about sharing information? Is it about giving them support? What does it mean? Then you can talk to your peers, your colleagues and your leaders within your institutions or the organizations where you work in, and see which aspects or concepts of family-centered care can you incorporate in practice. So I'll go back to the slide of the concepts. So among these maybe 6 things, what can we pick and run with? Can we start sharing information with patients? Can we start involving the family more in making choices as we discuss with patients? Are we able to have a formal way to give patients and families support? So you can look at some of these things and start incorporating them in your practice. These are some of the references that I used for the presentation. Thank you so much. I will stop sharing so that we can now take questions. Thank you.
Thank you, Dr. Esther, and thank you for really setting the stage for this, the launching day. I think some of the concepts that you brought up today might be new for some of our participants, so I'll just put it out there. If anyone has a particular question for Dr. Esther has been doing this type of work for many years now, and she's extremely passionate about it, which you can obviously tell, but we know, as she shared some of the challenges, we know that it's not easy. So would love to hear some questions or comments to Dr. Esther. She's made herself available to us today. Does anyone have a question? You can raise your hand or unmute. Esther Beatty.
Yes.
Thank you so much, Dr. Esther, for the presentation. So I just have a few questions for the context, just what one of the doctors in Senegal has told me about some of the challenges. And one of them is if you have a family that is polygamous, so you may have a husband with several wives, and often they don't get along, so there's a lot of conflict. So he's told me there's times where they actually have to not allow the family to be involved at all because of all of the conflict. So that's one comment question. Second one is, we've also been told, we just did our communication class, and for our case, we had a case where a woman was diagnosed with cancer, but it was her husband that was given the diagnosis. And so he did not want his wife to know what she had. So how do you deal with those kinds of situations where, I guess, one, there's a lot of conflict about different people in the family having different ideas about what should happen, and two, the family actually wants to hide the diagnosis and the prognosis from the patient? Thank you. Small question.
Yeah, just start off easy.
Yes. I'm thinking first of the polygamous family. So it's also a common scenario here that sometimes you get a polygamous family. Now, in practice, before we sit down with a family, it is good for the patient to point out which family members they would like us to have a discussion with. For example, as we are planning a family conference. So sometimes it's possible to plan and sometimes it's not, because sometimes they all show up together. So what we've done sometimes is to split that family conference, because these family dynamics and conflicts, you'll not be able to resolve them in hospital. And some of them are more marriage and family problems than health problems. So if the family is not able to focus on the health of the patient or the issues around the diagnosis, prognosis, or the issue that you wanted to discuss with, my way of practice has been to just actually avoid the family, yes, and deal with the patient. But sometimes we split the family and we are able to meet them separately and discuss the issues around patient care. And also that situation of having conflicts within the family does not result in proper caregiving for the patient. So sometimes it's good to also have psychological interventions so that the family members can stop focusing on their marital or family problems and start focusing on the issues around the patient and the illness. But sometimes we are able to achieve it, sometimes we are not able to achieve. I don't know if anyone has a comment on that issue. Okay, I can comment on the second question. If there's any other comments, we will welcome them. So the issue about disclosing diagnosis to a patient or prognosis, the first issue that we want to address is why, for example, a husband does not want the wife to know the diagnosis. And some of the answers we've received from family members is that we think this diagnosis is going to be very stressful to them. We think that they are going to die when they hear this news. We think that they cannot cope with the news. So it's to identify the reason why they do not want the disclosure and to try and support. In my experience, I've found that the family member who does not want a diagnosis disclosed most of the time is having anxiety over the diagnosis. So the family member themselves have not come to terms with that diagnosis. They're seeing my wife has cancer and they're thinking my wife is going to die soon. The treatment is expensive. So they're also still working through their issues and anxieties. So sometimes, again, we are able to give them psychological support and they are able to accept for us to deal with the patient. But this poses an ethical dilemma because your responsibility as a healthcare provider is to the patient, and the patient has a right to know their diagnosis, their prognosis, and their treatment. So when you collude with family members not to share a diagnosis with a patient, the paramount question is, are you really doing justice to the patient and is it ethical? So sometimes we insist that we need to support the patient, we need to support the family, and the patient has a right to know. My biggest challenge with that scenario has always been in the areas where we have a language barrier. Because when we have a language barrier, the family does not allow us to disclose the information to the patient. You are not sure what is being told to the patient. And if you do not have a healthcare provider who speaks the language of the patient, then you're actually not able to do much about that situation. Thank you.
Thank you, Dr. Esther.
Yeah, and I think that's sometimes the situation that many of our participants for today are faced as well. I know that many times when healthcare workers are providing care to refugees or displaced families, they may not be from the same community or same language. And I think that as we continue in this community of practice, hopefully we'll be able to learn a bit more about how people are coping with that and trying to do their best. Annalice, do you have any comments, or Ali, when you face patients where communication and language is a barrier? Annalice, what do you do when you can't communicate with the patient or the family? Do you have access to a translator?
Yes. We normally have translator, but you know, when you relay a message, the translator may maybe say something small. You see, you have said a long sentence, And then you just hear 2 or 3 words. So you wonder whether you have said was relayed the way you wanted it, or it becomes an issue also in the passing message to patients when it comes to treatment.
I wonder if we should invite them to our ECHO trainings, the translators. Maybe they'll
Yeah, and
join
I
us.
think it's easier. It's easier when the translator maybe is a healthcare provider, but when you're using a lay translator, sometimes they also interpret what you're saying and then give the message, a different message to the patient, because sometimes you've said a patient has an incurable disease that at this point we should be focusing on managing symptoms. A translator gives the message to the patient and you can see the patient smiling when that information is supposed to be very distressing. So you really don't know what information has been relayed. Yeah.
Yeah. Ali, do you have any comments from your work when you have to talk to somebody who is not from your same language?
I think, Erin, it's very important you have someone who will give you translation with the same language for you to help the patient well. Yeah.
I think one of the things.
Input.
Oh yeah, go ahead. Sorry.
Okay, I don't have more other input.
Okay.
But it's very nice. It's better for you to have someone who have same language with the patient. Who will take well the history and other examinations. So it's easier for you to have third personnel. Thank you.
And I think when we talk about palliative care, I think we should continue to acknowledge that the translators are part of our multidisciplinary team. I know that many clinics or government hospitals may not have access, but if you're working for a large humanitarian NGO or INGO, you may have access to a translator. And I would strongly encourage you to involve them in the team, especially when you are having discussions about a prognosis or you're having a family meeting. Having a small team meeting before you speak to the patient and the family really, I think, will help all over as you communicate and as you try to relay information in an honest and trustworthy way. And if the translator is having these same ethical dilemmas that we have as healthcare workers, that's okay. It's okay to acknowledge that some of these conversations are very difficult. If you have that kind of conversation in front of the family, it may be awkward. So having a small meeting ahead of time with the translator, with the nurse, with the clinician that's following the case may be helpful. So everyone is on the same page, especially because during those conversations or during the times that you're meeting with families, people can be very emotional. So if this was someone in the family that is seen as the head of the family, or they have a certain role within the family and they are quite ill and they may die in the next few weeks or few months, it might be very emotional. So just to prepare the rest of the team that it may be a longer discussion, or they need to be ready for those types of emotions, can be helpful. And not all healthcare workers are comfortable with that. Or not all translators may also be comfortable with that. So we can support them as well. Okay, well, thank you, Esther. Thank you for a really good discussion. And if anybody has questions, please put them in the chat. We will shift on to our next part of the call for today. Esther, I'm not sure if you have to go, but thank you for being with us, Dr. Esther.
No, I'm still here until the end of the call.
Okay. Thank you. So I'd like to take a minute now to introduce Annalice Otoro. Annalice, do you need me to share my screen, or will you share yours?
Please share.
Okay. So Annalice has been working with IRC in Dadaab refugee camp in Kenya for over 10 years. She is a registered nurse and recently graduated with a higher diploma in palliative care from Nairobi Hospice in Kenya. We can all clap for her. She did an amazing job. And she is leading the team for palliative care for her healthcare team. So we're really grateful. She's been a participant with Project ECHO for several programs, and now we're really excited that she's on our faculty team. She will actually be presenting at the conference that's happening with Kenya Hospices and Palliative Care related to this Project ECHO and online training. So we're quite excited for all that's happening in Annalise's career. And I will pass it over to you, Annalice. Just let me know when you want me to advance. Karibu. I think you might be muted, Annalice, because we can't hear you.
Thank you. Welcome all. So my name's Annalice. Once again, I welcome everyone. And we go straight to the case. Erin, next. As we go through the case, we like to be thinking about the questions. Erin. So the case is okay. We go through the questions. Question one is, when the government talks about universal health for all, does it include the migrants and the refugees? How best could we have managed the persistent fever in the case? And then, what is the best nutrition for patients with terminal liver cirrhosis and massive ascites among marginalized and very low resource settings? Next hearing. Our case was a 35 years old male who was diagnosed with the hepatitis that was on 11th of July 2019, and then a final diagnosis of liver cirrhosis, severe anemia, and massive ascites was diagnosed on 21st of January 2023. Next hearing. To look at the treatment and the significant investigations, patient was diagnosed with hepatitis in 2019, was to be started on ARTs, which is the mode of treatment for hepatitis, but declined and relocated back to Somalia. Patient came back in 2022 July with severe anemia, some ascites, and enlarged liver. Was referred for CT scan and revealed the liver cirrhosis, some ascites, and anemia was identified through lab works of full hemogram. Was started on hematemics, ARTs that was to be taken for 1 month, then come again for review and further investigation. But patient did not show up on appointments and was to be on 22nd, only to come back in a critical condition on 21st January 2023. Next. Next hearing. Now on conducting holistic assessment and brief pain and symptom, including relevant treatment. On the last admission on the ward, that was on 28th of August 2023, patient was in company of the wife, brother, 2 cousins, a sister, and a son who is 6 years. He was sick looking, emaciated, jaundiced, paper white, hot body, distended abdomen, was having swelling of the body, general body swelling. Then the observations at that time, blood pressure was 80/36 millimeter per mercury. Pulse rate was 160 beats per minute. Temperature was 41 degrees centigrade. SpO2 oxygen level was 80%. Random blood sugar was 2.8 millimole per liter. Then lab work was ordered. Full hemogram was, all the results were deranged, as you can see. Then liver function test also showed the deranged, high creatinine, very high urea, and then was put on IV antibiotics, IV fluids. Unfortunately, the patient had gone for referral at Garissa County Referral Hospital, came back with morphine syrup. So we continued the same for pain management. And then again, the physician, the MO, had prescribed for IV PCM for the fever. That's how we manage the patient. And the nutrition team also encouraged on nutrition, and he was being provided from the nutrition team. Mental health team had to come in because of support in counseling the patient, and because the patient could not sleep at night, he kept awake throughout day and night, he could not sleep, so they had to come in and support. Next. On the psychosocial concern, the patient is a fourth born in a family of 11, alive 3 brothers and 4 sisters, is married to a 22-year-old lady and blessed with 5 kids, 3 sons and 2 daughters, aged 7, 6, 4, 3, and 1.5 years. The wife has been the caretaker throughout the life of this patient when he was ill, and with the support of the other family members. He is a Muslim by faith, but he could not attend prayers as required because he has been ill on and off. Since 2020, the condition deteriorated. Relatives and himself are wondering if there is forgiveness, then why God permits those of low economical status suffer a lot, and why other conditions are regarded as more important than others, while others special to others. That is the case when it comes to referral, because when they request a referral, maybe it takes long, or maybe they could be told that you will not be permitted. Now they keep on asking such questions. Next. Then family center concern, family concerns and dynamics. They were hopeful that when they are referred back to Garissa, maybe they could have an operation done, while maybe he could be healed by such operation. Then rather than the ascetic fluid tapping that was going on in the hospital, at the same time they left it all to God as they saw their own in pain. Having seen that there was not much being done, then they believe that the patient dying around their own, with the spiritual leaders around reciting the prayers and everything over the patient, it could have helped more than to relieve the pain and to bring comfort both to the patient and the family. So they opted to go home, but fortunately, the patient did not stay more than 2 days. He passed on 2nd of October 2023. May his soul rest in peace. Next, Erin. Then on communication, as much as the language speakers try to interact with the patient, it is very difficult, more the convincing way. We meet resistant as the healthcare workers who do not speak the same language with the patient. It is not easy, because when you are using a translator, the same translator is the healthcare worker you are working with, then there are so many, he's leaving you, he's going to another patient, or she's leaving you, going to attend to another patient. You keep on interrupting with the conversation, so the patient gets less information than what you could have given if you have just a translator with you throughout the session. Then the privacy and the confidentiality, maybe we had rooms, but for our facility, we just have an opening where even when you want to make a confidential or a private meeting with the patient and the relative, maybe also the family member, it becomes difficult. Even outside the environment, that is how difficult it is for us here. Then the patient condition also was changing. From today you go, you find him a bit better, he can answer your question. Next you come, he's down, so it becomes also an issue. You cannot relay the full information that you wanted the patient to get. Next. Then on the spiritual assessment of the patient was hopeful, the family were hopeful. Spiritually, patient, family, and the community held on the trust that only God can heal or decide the fate of the person. But recitation of the Holy Quran over the sick person is very important and acceptable through the sacrifice made by the health family members of the patient. So they will wish that they go and make some maybe gathering, they pray, and then when they pray, some okay, they get healed, but others, when they pass on, they believe they have gone the right way. Then with that, we convince them that prayers can be done. We just try to convince them that prayers can be done even in the hospital setting, but they feel it is more private at their home level than in the hospital where everyone is looking and commenting. Next, Erin. When it comes to collaboration and the partnership, although the team could not be strong as what is happening over where with other settings, but we have managed to try so that we can bring you on board at least some other partners in the community who are serving the community. Some were working on the livelihood, others are working on nutrition, others are working on education. Like that, we have the physiotherapist working for the handicapped. So we normally bring them on board when we have somebody with disability or physical impairment. So they come and work. Like our patient needed some physiotherapists, they needed spiritual leader. Actually, he needed nutritionist, so we were on board. We have a team that consists of our nutrition team and mental health, and the handicapped team also, we normally invite them over. So at least we collaborate like that. Even when we are missing some drugs, we can ask from our neighboring agents, Red Cross and the MSF. Next. So in summary, this is a 35-year patient with the advanced stage 4 liver cirrhosis, massive fasciitis, and severe anemia. There is a fourth born in a family of 11 children, married with 5 kids, all under 7 years, and a wife of 22 years. He had several admissions and referrals for special investigation and care. Last admission was on 28 August 2023 up to 30th September 2023. The lab and other test results were either abnormal or subnormal. Patient and family members remained positive even when the they attempted to request referral failed. Thank you. Next. So as we end our case presentation, we like to go back to our question when the government talks about universal health for all. Does it include the migrants and the refugees or the marginalized? And then how best could we have managed the persistent fevers in this case? What is the best nutrition for patients with the terminal liver cirrhosis and massive ascites among marginalized or those at very low resource settings? Because to get some items in our setting here is very, very difficult. So please, we discuss. Thank you all.
Thank you, Annalice. Thank you so much. Yeah, we'll open it up for discussion. If any of the participants have any other questions for clarification on the case, now we will move into time of discussion, and then we'll allow some of our faculty members also to give suggestions or recommendations on this case. Anyone want to start off the discussion?
I would like to ask a question. I'm just listening to this case, and it looks like the patient had liver failure at the time of presentation, but the family was keen on a referral. So I'm wondering whether the family understood the diagnosis well, although Annalice mentioned there was an issue of translation, because I don't think a referral would have saved the life of this patient, even in another level facility. The patient already had hepatitis, liver cirrhosis, presented in liver failure. In fact, he seems to have been presenting in end of life with hypotension, fevers, ascites, but the family seemed to believe that if the liver was removed, then the patient would get better. So I'm wondering if they had understood what was happening in terms of the diagnosis. Thank you.
Annalice, do you want to comment on that?
I want to believe they understood, but maybe because when they are going for referral, the patient will go only with one person. And when they brought back the result, they did not bring it back to the hospital for interpretation. They just kept at home, and they now came to the hospital at that last moment with the results. When we are trying to interpret the results, that's why they could not understand that this is an end stage of the patient. And that's why they were still requesting for further referral. But they were told, the person who took the patient was told that the patient has a end stage 4 liver cirrhosis, and it cannot be operated on. That's why they were just given pain management and some few antibiotics and released back to the camp for palliative care.
Yeah, it sounds like there was maybe potentially some confusion about how serious the illness was, and maybe because it was a referral center and it wasn't where the patient ultimately was from. Maybe there was also some worry that the referral center didn't want to be giving such difficult news. I'm not sure, but I'm sure it does happen a lot. Bang, would you like to comment?
Yes. Good evening, or maybe good morning in some countries. Yeah. Are you getting me now?
Yeah, we can hear you.
Good. I can direct my question regarding about the translation. I know in the translation, sometimes there's some people who know how to translate very well, especially the field are the field are different. Like if you translate a patient, but there is another medical term word that need to be also narrated to the patient. So what I can ask is, like, for example, the clinician or the medical doctor who did the investigation together with the translator. So he or she really knew that the translation was done officially. Because, for example, the patient, most of the patient, by the way, they only believe when they heard that there is a repair, or like if they were told to be repaired somewhere, but they saw that they may be healed. So I don't know if the patient or the caretaker get a full information regarding about the diagnosis that had been mentioned by one of my colleagues, because if they were not aware of the diagnosis, they may thought that if that patient was transferred somewhere, he may be healed. If they were not told that this sickness had no cure, even if the patient will be transferred. So I even also want to know, is it really true that the clinician or the doctor who did the assessment for the patient had the full information, like the translation was done correctly? Because it seemed like the patient plus the caretaker, maybe they were not convened. Yeah, that is my question.
Yeah, and I think this is what some of the issues we've talked a lot with the team in Dadaab relating to referrals. And I think a lot of times we think if a patient is able to be referred, then somebody else will be able to manage the patient. They'll give good advice. Hopefully the patient will be cured. And I think even Dr. Esther has alluded to the fact that there are many times that these patients, when referrals try to occur, that patients are very sick. And it's not easy to continue to support. Palliative care is not easy. It's not easy to continue to support patients and families when they hear very difficult news. Obviously, his wife is very young and has many children to be responsible for now. Sounds like they have a big extended family, yet I'm sure there's also been a lot of trauma and loss in their family already. So I think some of the resiliency of the refugees is to continue to push and hope for cure at all costs. But when it is inevitable, it is very difficult to know how to support patients as a healthcare worker when they don't want to acknowledge that because it's so difficult and it's so painful and it's so hard. Tawane has asked, was it a self-referral or were they referred from IRC? Annalice, I think there's quite a process for referrals. Do you want to explain the referral system in Kenya to get out of Dadaab? Annalice, are you still there?
I'm still there, but moving.
Sorry.
Come again.
What is the referral system for you? The question was it a self-referral from the patient and family, or were they referred by the medical facility?
The referral system is through the medical facility and the UNHCR. So
through UNHCR.
And the fact for the first time when they were referring for the investigation, that one was accepted because it was still at the early stage. But when it comes to treatment and medication, it becomes difficult because I think it's a bit expensive. So referral also becomes impossible.
Yeah.
Yes.
We've talked about this a lot with our team at UNHCR just a few months ago when we did the introduction to palliative care, how many times referrals can be very challenging when you have patients that present with advanced disease, because facilities and organizations like UNHCR are hesitant to support in Kenya referral when the outcomes, as Dr. Esther had mentioned, may not be leading to cure. So it is very difficult for patients to get specialized treatment. And it sounds like in this situation, they did initially, but then obviously the patient got quite sick and quite ill. So then didn't qualify for another referral. There's some other questions and comments in the chat. Leah says the family needed psychological counseling because they worked emotionally by attending the patient for so long. And I think this is something we would like each of the participants to acknowledge in this case. This patient had been sick for many years, since 2019, and seemed extremely symptomatic. So being a caregiver, being a wife, I assume she was the one that was giving a lot of the care, or family, siblings. She also had a lot of responsibilities with many children to take care of. The amount of psychological counseling that the caregiver and family needed was really extreme and very large. And it sounded like the team at IRC was trying to make quite a large multidisciplinary kind of teamwork to the situation. And I think they did a great job in that. Obviously, there are different ways that we can improve. And I think if there's someone that the patient and the family seem to connect well with, that person is able to give psychological, potentially palliative care counseling, or talking about very difficult subjects. If you've had the training, that can also be very helpful to, especially as we talk more in the future about grief and loss, or anticipatory grief. The emotions that family members go through as their loved ones are dying is very serious. And we can stand beside them and continue to support them. One question from Millicent. Was there a system of follow-up, especially with social work department, for the client as they were initiated on the ART? Annalice, do you know what kind of support was given in terms of the chronic illness from 2019? Of course, that was COVID. That was a terrible time for everybody. I wonder if that has something to do with it. Annalice, do you know what kind of follow-up they had with the clinic? I think Annalice is going back to work. Annalice had a very busy day, so we're very grateful that she gave us time in her day, but I know she's at work. And then there was some questions: was the patient transfused? Oxygen therapy is necessary. Some comments: someone who's diagnosed with liver cancer should avoid animal protein. Dr. Esther, do you have any thoughts?
I would like to comment. I think refugees face a very big challenge in terms of accessing care, because one of the questions was about the universal health coverage. Now, I am not sure if this is covering refugees, but still the concept of universal health coverage is about the access to primary health care. So it's not about specialized care. It's about the primary health care being accessible to everyone. So there's still some gaps when it comes to access and who will be able to access what. Because even as Annalice was going through this case, I'm thinking about, this is a patient who needed palliative care. And the question that came to mind is, in that camp, the patient was where? In Dadaab. Is there access to palliative care trained people? And then what would the team be like? Because you can find maybe you have just one nurse who is trained in palliative care. There is no team. So they are not really able to give optimum care to the patient, even when they wish to do that. So the referral systems is a problem. Access to care is a problem. Follow-up is a problem. Yeah, I think there's a lot, even for the staff working in that humanitarian setup. They also need support for themselves, because I think these challenges are more than what we experience working in mainstream healthcare. Thank you.
Yeah, this is something we've talked about a lot as we've worked with the team in Dadaab for a few years now. Currently with the main 3 facilities here in Kenya that are providing support for refugees, MSF does have a palliative care team. They are small and in a certain area. They have been providing home-based support, but they are very lean. They have, I believe, 1 nurse and 2 clinical officers that do home-based visits. They're able to see and have a rota of about 50 patients that they see through home care visits. Annalice is the only palliative care trained healthcare worker working with IRC. She currently doesn't have a palliative care role on the team. She does her nursing role, and then does her palliative care consultations and visits on top of her work. And the Kenya Red Cross, I don't believe, has an official team but they have attended some basic introduction training. So there is a huge need, definitely in the camp in Kenya, because the number of patients they see that have palliative care needs are quite great, and the amount of referrals are very few. People like Ali Hamis used to work for these large international humanitarian organizations. He's now in a private clinic and he does some consultations, but there's probably less than 5 people that are confident in providing palliative care right now in Dadaab, and we're trying to support them well. But I hear you, Dr. Esther. I think there's a huge need to better support these patients and families. Ali, do you have any comments? Because it's from your area, from Dadaab.
Thank you, Erin does. I don't have more input, but for the last questions that Annalice was asking us about how we can give nutrition to such a patient who is having liver cirrhosis. One of the best input I can say is they can avoid an animal protein, and we can manage him at the hospital level in case the patient needs IV fluids and IV antibiotics. They can still manage him with we can still manage with the patient lactulose or biscuit diet if there's no defecation during that sickness. So I don't have other input. Thank you.
So continuing with symptom management, seeing what are some of the main issues the patient is facing, I think it's really important, like you're saying. Continuing to support the family is also important. If you believe that given the system, the current system right now, and referral for other support is not possible, making sure that you, as the healthcare team, support the patient and family where they're at. It's all really important. Sarah, do you have any comments?
Yeah, I just wanted to say, given the incredible restrictions in providing palliative care in this situation, I think something that I noted as well in your presentation, Annalice, if you're still there, is that the family did express a wish, and also the patient a wish, to die at home and to be with family. And I think that recognizing that in the end that happened for them is important. And that's one of the really important things about delivering palliative care, is to be able to honor those wishes, even if they don't always make sense in the moment, hospital versus home. But that's a positive thing maybe from this case.
Yeah, it's a good point, especially as we continue to provide care for patients with very serious illness. We need to, in a very culturally and family-centered way, try to identify things we can do to support the family. And if that wish was to return home and we felt that the patient would most likely die in the next few days, if there's ways for us to do that, we should put all our efforts into providing that for the family, and that being their last memory of their loved one, that they would be able to be at home in the privacy of their home to support their loved one. I think that's really a very good point, Sarah. Thanks. Some good comments from Lamek related to nutrition. I think some of this would have been really great, and I hope the patient was able to access this when they were originally diagnosed. That would have been really helpful. All right, well, I think we are just at time today. I thank each of you for being with us. We're really grateful and we're thankful for the kickoff to this community of practice. Our echo is a little bit different than in the past when we've run echoes before. We don't have an attendance sheet. When you joined the echo or the call for today, there should have been a pop-up that came and asked for you to click your attendance. So hopefully that showed up. And if you do have time, I'll just post a link here where you can give us some feedback. If there's something different you would like us to do in the future, you can let us know. But thank you so much for being here with us today. Our next session will be in November. It will be the third Tuesday in November on November 21st. And we're really looking forward to having you with us. Again, if you're interested in sharing a case from your team, the same as Annalice did, we would love for you to get in touch with us. I'll put my email in the chat here, and you can reach out to us. But otherwise, thank you, everyone. It's great to see you. Thanks for being with us. And we'll see you next time. Bye, everyone.
Bye. Bye.
Bye.
Mhm.